All right. Good morning, Dr. Lim. Thank you so much for joining us again.
Thanks very much for inviting me, Rebecca. I'm
Yeah.
just really thrilled to be here. I love what you guys are doing and the momentum you are creating. So to be a part of this is a great opportunity.
Thank you so much. And we love having you. And for anyone that has not read your book yet, I'll make sure to put a link in the show notes, but parents can also find it on our recommended reading list. And it is a great read, let me just say, for both parents and clinicians. If you haven't read it, check it out. Just the way you explain everything, you put it in such terms that parents can understand it, but it's still very informative for clinicians. So it's a great book.
Yeah, appreciate your support and promotion of it. I think this information, it takes a long time to be able to connect all these dots. And so I really wanted to make it easy for not only parents, but other colleagues who need to convey this information as well.
Yeah, we talk about that a lot. This is not something that is talked about in dental school or med school. So yeah, we're happy to be a conduit to help get the word out and promote your book, because like I said, it's fantastic read and it's really informative. And before we dig in, I just want to let any clinicians know that if you'd like to talk to Dr. Lim or hear more, you can join us at Airway Palooza in 2024. She will be speaking there. And she's also going to be signing copies of her book at the event. So kind of an exciting opportunity.
Yeah. I'm looking forward to that event. I really wanted to be a part of it because there's such a big lineup, and I think I'm looking forward to the networking as well.
Yeah, it's a great event. We're excited to be a part of that with our partners, Airway Health Solutions. So with that said, let's go ahead and just jump into our conversation today. Today, we're going to talk a lot about palate expansions. As you and I were talking a little bit before we started recording, it's a hot topic, and it's one that parents have a lot of questions about. We receive a lot of questions. So let's just use that as our jumping off point. So what is palate expansion and how does this work?
Yeah, so palate expansion really is about widening the top jaw. And why do we want to widen the top jaw? Really, that top jaw is the floor of the nose, and it's the housing for the tongue. And it's part of the bony framework that supports our upper collapsible airway. And so when we can develop the jaws to their full potential, it is actually going to optimize our breathing passages and our sleep, which is so key for children to function really well. And so with a palate expansion, the way that we do this is we use an appliance that's worn inside the mouth, usually 24/7. And there's normally some sort of screw mechanism in the middle. And so the palate has two halves. There is a midline palate suture. And when we can separate the two halves of the palate with a gentle expansion force, by turning a little screw in the middle, it actually stimulates bony expansion in the midline of the palate, which corresponds to the nasal floor. And so palate expansion is really well studied and proven to improve nasal airway and improve nasal airflow. And in some cases, it can be a really effective treatment to help with obstructive sleep apnea in conjunction with other procedures, such as removal of the adenoids and the tonsils.
And I just want to clarify, because as a parent, when I first heard this, I went, and I think Dr. Liao explained it, that it's about a hair's width. So when you say you're turning the screw because we're widening it, it's not like you're taking it and going on a kid each time. It's these very subtle, just over a period of months, correct?
For sure, yeah, it's imperceptible to a child. So the most commonly studied and used rate of expansion is in the range of 0.25 millimeters a day. So that's considered semi-rapid rapid palate expansion. And so I use something like half the rate of that. So a lot of different providers will use different things, but we know that 0.25 has been really well studied, minimal side effects and problems with that. And so we really want to do this when children are younger, because around the age of 9, for instance, that midline palate suture becomes more fused and it's more difficult to separate the two halves of the palate. So we may not get those changes as much as we work on teenagers and older adults. If we try to apply that separating force with traditional expanders, we're going to tip or move the teeth, which is not quite the same as getting new bone in the mid palate.
So, but we can use this on older children and adults, though. It's still effective. It's better if we can do this when they're younger.
Definitely better when they're younger, and we can make greater changes when they're younger. There are other options that are available for older children that have particularly bad breathing, particularly narrow palates, that actually can make it more effective. But yes, generally the younger the better, because when we have a narrow palate and we're not breathing optimally, we want to restore that better breathing and sleep in the earliest years of life. When children are growing rapidly, we know that even problems like mouth breathing may be associated with more problems with attention and concentration, and this can impact a child's future learning. So the earlier on we can treat it, the better, because the traditional approach is really to do it at age 7 to 8 years. And at that time, it's more about how can we make space for the teeth to fit. But from a functional point of view, more and more people are recognizing that this intervention plays an important role in helping with nasal breathing. And so we don't necessarily need to wait.
And how early, when you say younger, the better, how early can you explore this as an option for treatment?
It can be done when children have all their baby teeth through. So I have colleagues that are working on 2-year-olds, but my comfort level is around the age of 4. Yes, and I don't want to expand every child at age 4 either. So like if there's not too many functional concerns, I may be more inclined to wait a little while. My favorite age right now is around the age of 5.5 to 6, if there's no big concerns with how a child is functioning. I prefer to get in before the adult teeth start to come through, because sometimes if the jaw is too narrow and all the baby teeth have no spaces, what happens is all the adult teeth tend to crowd in, and they may erupt through in the wrong position. So I kind of like to get in earlier before the adult teeth come through. So I guess what I really want to let people know is that it has a really important role to help restore nasal breathing in certain children, but it can be very difficult sometimes to find the right providers that are on board with doing the early intervention, which can make it challenging for parents. And, we have that potential to do it as they get a little bit older. So don't get super upset if you can't find someone to start at age 4.
Right. Or if you've, quote unquote, missed the boat and, now you have a 13-year-old, you can still do this. It's not too late. It's just going to be different, correct?
More complex, difficult, because what I found is starting younger and younger, what I notice is the quicker that we can restore the nasal passages and the tongue space, children can function better. It's easier for their muscles to adapt. Even things like speech. I've been recording a lot of speech before and after treatments, or before the treatment, and just seeing how the tongue fits inside the mouth. Because I see a lot of patients that are referred to me with ongoing speech problems despite having quite a lot of therapy, speech therapy. And what I notice is many of them, their tongue can't fit properly in their mouth. And so sometimes when we do the palate expansion, there are changes in the way that their tongue works. And they don't have to overuse the muscles of their face and their lips and that as well. And so I do think there are functional benefits, not just sleep and breathing, but even with their speech and how the mouth works, that we shouldn't really be ignoring.
And since you mentioned functional therapy, if this is a treatment that's proposed for your child and you're looking at it, would you do, tongue tie releases, myofunctional therapies, things before you start this course of treatment, or is that something you do in conjunction? How would that work if your child was a candidate, let's say, for a tongue tie release?
Yeah, typically if a child is 4 and above and they are due for a tongue tie release, my preferred option nearly all the time is to do the palate expansion first.
Really? Okay,
why do I want to do this? Well, I want to restore tongue space, because for me, usually doing palate expansion is quite quick. I can do it within 6 to 9 weeks. to get the mouth where I want to be and to create that tongue space. So we can get the tongue working better, and we can do better therapy if they have more tongue space. And the other thing is, I know that a lot of the time when children have a tongue tie, they have a low tongue posture, and they're going to have some symptoms of poor breathing and sleep, or it's not quite optimal.
Okay.
But I do think the quickest way to get good sleep is to do the palate expansion, usually, because it's less compliance based. We just ask parents to turn a screw, and we're kind of changing the mouth and the way that a child can breathe compared to the tongue tie release. If we're trying to restore the proper tongue to palate suction and posture for better breathing, we do need to do myofunctional therapy. And it's compliance-based, it's a lot of effort. There are some people that are quite busy and they find it difficult to do this with their child, or the child might be a little bit little. So if I want to affect their breathing quickest, I'll usually go for the palate expansion first. And then it just becomes an easier process for me. I've tried all sorts of different things, but this is the way that I think is the most efficient and impactful.
And that totally makes sense. So, but when they're younger, you mentioned 6 to 9 weeks. So in these younger children, I mean, it's rapid, it's really fast.
Yeah, and parents really can see the facial changes quite often, or little spaces appearing between the teeth, baby teeth. And yeah, I hear parents a lot of the time, they're saying things like, oh, my child's sleep is less disturbed. They're not moving and tossing and turning, or their mouth is closing, because their tongue can actually fit properly. And it just translates, not to promise everyone this, but it translates to a more rested child who's able to cope better with their emotions and not so tired. And so that's why I like to approach it this way first, because I do think it's more predictable and less compliance based. And if they're going to need it, that's a good time for it. There are other people that will say, oh, they think a child is really young, we can do tongue tie release, we can get the tongue working better, and that will stimulate the palate development in the right way. But for me, I actually believe that if a child has had some sort of tongue tie or mouth breathing, there will be a deficit in the way that their jaw has grown. And I'm going to want to restore that quickly in the most predictable manner. And having seen a lot of adults with snoring and obstructive sleep apnea, and seeing that this poor palate development or narrow palate is a risk factor, I want to get in there and see what I can do, even if it's 5 millimeters, a small amount, because I do think that's really impactful symptomatically for many people. So I'm not really shy about palate expansion. If it was my own child, I would prefer them to just get it done and not have to rely on the tongue to do all this work. I'd rather get that quick boost. But there are so many different ways of approaching it. So I don't want a parent to feel bad that they can't get it. I think, go to your different providers and see what they can offer and what is their approach. And it doesn't always have to be done the same way. But that is just what I have noticed, being able to do various approaches and having those skills to do the palate expansion. I kind of think it works.
And when we're talking about this expansion, it's not just laterally side to side. You can also use this device, correct, to bring the jaw forward or to impact it in other directions?
My favorite appliance is called the BioBlock. I can just grab one if you like.
That'd be great. Yeah, absolutely.
Yeah. Sorry. I hope you can edit my thing out. But if you have a look at that, it's a little removable device. Okay. And it actually has these wires that sit behind the back teeth. And so as we are expanding laterally, or the width of the palate, it actually uses these wires, and it's really moving the front teeth. So I can actually convert a V shape into a U shape. So it's really bring that, changing the whole shape of the upper jaw. So for instance, sometimes patients have an underbite where the top teeth are sitting here and the bottom teeth are sitting out the front. it's related to a midface deficiency where the upper jaw hasn't grown in relation to the bottom jaw. So it's not quite sitting well. I can use these wires as well, if it's not particularly severe, to kind of nudge those front teeth into the right place.
Wow.
And then it creates a tongue space, and we can get that tongue working up and promoting better development as well. So that's really why this particular appliance is quite impactful, and why I like using it, despite the concerns that we may have with children complying with it. Children are maybe more prone to flicking it out of their mouth and playing with it. And I have ways to test whether or not I'm ready to work on a child and how compliant they'll be. But yes, this is why I love this particular expander. I think it really produces some nice facial results.
And you mentioned it is it's a device that can be taken out. So do they take it out when they sleep, or do they take it out when they eat? How does that work?
They actually wear it 24/7. They wear it to eat, to sleep. They only take it out to brush their teeth. And when they brush their teeth, their parents can turn the key.
Oh, wow.
Okay. There's a little screw in the middle.
Mm-hmm.
So as you turn the screw with a little key, it separates the two halves. And that produces the force that separates the two halves of the palate, so that we can stimulate the new bone.
And when they're younger, you would turn the key every day. What about
yes, I
when
do
an
the
older
same
child? Do you do the same with an older child, like a 13, 14-year-old?
Well, in my practice, I'm really focused on that 4 to 9 year age group, or 4 to 8.
Mm-hmm.
So I don't know. I haven't tested it enough in the older children. But definitely the older and older a child gets, it's more difficult to separate those two halves of the sutures, two halves of the palate, and we're going to produce more dental movements. We're going to tip the teeth. Yeah, so I can't really comment on those teenage groups, but my preference is to work on the younger children, because I know it's more reliable, and that's what I see. I see good results with it.
So with the younger children, let's say you start on a 6-year-old.
Mm-hmm.
Once you've achieved, the widening to, the optimal width, and everything's fitting nicely, is there any kind of follow-up? Because I know, for example, with braces, there's follow-ups that they do. There's the wires in the back, or there's retainers. What does that look like post-treatment for a younger child?
So post-treatment, I get the child to continue wearing the expander without turning the key, because that's going to be like their retainer. But I usually want to let parents know that most optimal retainer is the tongue, lightly suction to the roof of the mouth. And so as we can get the tongue better functioning, I will actually start weaning children off the expander, maybe during the daytime first. And then as things get more and more well functioning, we want to reduce some of the nights as well, to reduce the reliance on this. So how do we get the tongue back up? Well, I want to introduce my functional therapy, which is exercises to promote better muscle function and better muscle balance and tongue control and isolation and strength coordination, those type of things, because we want that tongue sitting better. And some children will need tongue tie release, because if their tongue is tethered and they can't get their tongue up, the tongue tie release will be an important thing to do better therapy. So the tongue tie release itself is not going to get the tongue working well. It's actually the therapy that gets the tongue working well. And the tongue tie release helps to do better therapy. And the other thing that I like to use is habit correcting devices. And people might have heard things like Healthy Start or Myo Brace. Those type of appliances are trainers to help children close their lips together, to restore nasal breathing, to promote nasal breathing, to help them swallow better without overusing their lips and cheeks. They tend to disengage all those muscles that would normally have overworked and created the collapse of the mouth in the first place. And it has a tongue shelf, so we want to promote better tongue posture as well. So these are the things. It's not really quick. Like, expansion is super gratifying and parents love it. It can really create a big change quick and functionally works. But we need to understand that we need to follow up and get the muscles working better. We need to achieve those goals of tongue to palate suction, lip seal, nasal breathing, better swallowing. And I think that's what's really difficult. In the past, a lot of orthodontists have done palate expansion, and they say it doesn't really work because it's unstable. It tends to relapse, but that's because the underlying muscle dysfunction has been overlooked. And this is why now there's more attention to myofunctional therapy and tongue tie release. And so to incorporate that into, orthodontic practice, it's challenging when you've got a model of seeing children and having the braces. You actually have to kind of follow this up for quite a period of time to make sure that children are meeting those goals.
And that's what is at the base for this kind of, I'll call it, for lack of a better word, controversy around it, right? That because we hear this a lot. Those are questions we get from parents. I was looking into this, but my provider, orthodontist or dentist, is saying no because they don't work.
Mm-hmm. Yeah.
So it's probably more around they're just not doing the full components. They're not doing the follow-up perhaps with myofunctional therapy and things like that.
Yeah, for sure. Because even within my own patients, I have seen times where people might have lost a plate and they haven't really progressed with orthodontic treatment. And yes, you will get relapse. So when you expand bone and you doing that, stimulating that distraction osteogenesis, where you've sort of separated the two halves of the palate and you've stimulated bone in that center, the bone itself tends to be quite stable. It doesn't actually tend to shrink. But what tends to move is the teeth, because the teeth erupt or they stay in the equilibrium zone where the pressures of the tongue on the inside and the pressures of the lips and cheeks on the outside are in balance. It's called the neutral zone. And so if we really haven't changed anything about the tongue or the lips and cheeks, those teeth will tend to go back to those original positions.
And that makes sense. So as a parent, you have a 2, 3, 4, 5, 6-year-old. How do you recognize that, hey, this might be something good, that an option, and then maybe I need to talk to my provider about this for my child?
Yeah, I mean, 2-year-olds are very difficult to work on. What sort of 2-year-old would benefit the most? Very significant, narrow, high arch palate. So when the palate is very narrow, and usually these children will have open mouth posture, low tongue, their mouth will just be hanging open. So there's some sort of low tone around the mouth, which has contributed to that narrowing. If a child is snoring, so those children combined with factors like snoring and obstructive breathing, in terms of what their daytime function looks like, it could be just a very difficult emotional regulation, or really poor attention concentration, tantrums, meltdowns, big 2-year-old type of behavior, which can actually be related to their disturbance of sleep quality. So they're the type of children that may benefit more from early intervention. And we don't want to panic, because it's not always easy to work on a 2-year-old or to find that provider that will work on it. But I do work on them. But I do think it's important to recognize the important contribution or impact that this can have on children, so that we're prepared to act at that soonest opportunity.
And every child's different, right? So some 2-year-olds may tolerate it.
Yes, that's right. Yeah, personally for me, I can't even see 2-year-olds in my practice because we're so busy, right? So you're not always going to be able to find that right provider. But yeah, as children get a little bit older, other clues might be lack of spacing between the baby teeth, or anytime we have problems like cross bites where there's a little bit of asymmetry, the teeth aren't fitting together, the jaws aren't fitting together. Usually if they're not fitting together, we know that there is an underdevelopment of the palate. Yeah. And even like lower teeth crowding, all these problems, when there's lower teeth crowding, it usually means that there is a small upper jaw. So the first step is, let's get that top jaw correct, because everything on the bottom will be constricted if we have a small jaw on the top.
So, okay, I had a question, but I would like to change that now. I'll come back to that. So, because you said if you see lower teeth crowding, that usually means that it's a smaller upper jaw. Is that because the upper is somehow squeezing the bottom? Or how does that work?
Absolutely. Definitely. It's squeezing. So I think it's quite normal for the lower incisor teeth to erupt on the inside. So there will be that stage where they're not quite right. But then anytime there is that lower crowding, yeah, it is a reflection that the top jaw is not growing well.
Okay.
Yeah, so
Did not know that.
often what will happen is I just do the palate expansion on the top and we can actually see the lower teeth unraveling.
Oh,
Yes.
wow.
Yes. But the other thing that contributes to lower crowding, I mean, there is a dysfunction. So if we see like a child that has a lot of mentalis strain on their lower chin, dimpling when they close their lips, that is the type of pressure that actually can contribute to the lower crowding as well. So sometimes after the top jaw is, we've got it to the right spot, we still need to address that dysfunction to help with the unraveling. But the
Okay.
younger a child is, I find the more automatic things fall into place. But then when
Right.
we've got an older child who's like more like 7, 8, they have more ingrained habits. It may be more challenging, but yeah, it still can be done.
It definitely
We
can
just
still
need
be
to
done.
address the top jaw.
What do you, w- trying to figure out the right way to ask this question. I'm not asking for a product endorsement. I'm asking for just the treatment, this kind of treatment, especially for younger children, maybe a 2-year-old that needs work, but probably can't tolerate a palate expansion at this point. What about
Mm.
something like a myomunchie or that kind of a tool? How would that work as a precursor to getting them ready for palate expansion?
Yeah, when I was seeing a lot more toddlers, that would be something pre-orthodontically, because I think that if a child can breathe okay through their nose, then they can actually pop a Maya munchie in to actually start chewing. And, we know that at the end of the day, we're going to have to address the muscle problem and the structural problem. So we can actually just start using the Maya munchie to help promote lip seal and good chewing and jaw exercise and better swallowing, where they're not thrusting their tongue out forward and it's disengaging all the muscles, the ring of muscles around their lips and cheeks. So those ones that tend to inward distort the palate. So yeah, I do think there's a lot of value in using the Maya munchie. There's compliance as well. It can be a little bit difficult, but where possible, if a parent can work with a child and slowly build their child up with little increments, 20 seconds, a minute, I do think that there is a lot of value, because children are so moldable at that age of 2 years old. And when we can really get the muscles working in a better way and they're growing so rapidly, I have actually seen some really nice changes with that as well, particularly people that give up dummies or thumb sucking or pacifiers for American people. When we can get that and try to retrain or change the muscle habits through a Maya munchie, I've seen some really nice results. So not all is lost by doing that first. I think that is really quite a good option. And a lot of, not a lot, I've got a couple of colleagues that are using Invisalign, which is, I don't know if the aligner, clear aligners, because they've actually found it quite helpful in that population to move things around. Now, it's not going to, yeah, because they found that they can adapt better to that. So I have a couple of colleagues that are doing that. And what it does, it actually sort of moves the teeth around and it actually creates more tongue space. I don't think it's necessarily proven to create that same nasal airway remodeling, like where we get that new bone in the mid palate, like expander with a screw does. But even creating tongue space could be helpful for some of those children, or that's what they're finding. And I do think that the company is starting to look into how can we actually make it possible to get more of that bony expansion in the mid palate. So, there's going to be new innovations that are being examined.
Yeah, of course. So, and by the way, thank you for clarifying the dummy thing, because for those that are listening and not watching, there was a head tilt on my part, like, what? Hey, what? What did you say?
That's good.
What are some other things that parents can do? And again, I'm really talking about this younger group that may or may not be able to tolerate an expansion. specifically around maybe nutrition. One of the things we're hearing right now is, and we've all done it. So mom guilt, put it aside. We all did this. The little the pouches. So we all
Yes.
know from this point forward, pouches are a no. But what are
Mm.
some other things that we as parents could do, especially with our youngers, to help stimulate this palate development and drive it in the right direction?
Yeah. So we want to minimize pacifier use because that alters the tongue posture. It keeps the tongue low. So minimizing that and any sucking habits. Yeah, the chewing is really good for children, making sure that they have clear nasal passages, that whether it be nasal sprays to do nasal clearing or to investigate further if there are nasal obstructions, such as enlarged adenoids, or if there are enlarged tonsils that may promote mouth breathing. We want children to grow up with their mouth closed and their tongue up if possible. And there are other people that are more skilled at dealing with younger children through feeding therapy or motor therapy, getting the mouth working better through toys and feeding and the way they introduce foods and where to place them. So there are other people that can be looked at, such as speech and feeding therapists as well. And there are little things that I think children should be able to do. I do think that if I see it like a sibling come in the practice and I'm not going to see them yet, I do think myo spots, like they're little spots that can be placed in the mouth to train the tongue up. So for instance, today, one of my patients had a brother that was only really young. So I just suggested, he was watching TV with his mouth hanging open, and I couldn't really understand his speech. His speech wasn't super clear. So I just suggested, they've been using the spots for the older child. Why don't you place the spot inside the child's mouth where they put their tongue and say N? So the idea being, we try to get children to melt the spot, to use their tongue and press that tongue on that spot. It's like a magic switch. When their tongue touches it, it lights up bits of their brain that's involved in neurotransmission, not for the parents' purposes, like dopamine, serotonin. It makes them feel calm. So we want that tongue up. And he was pretty keen. He's seen his sister do it all the time. And when the tongue tip is up in the right spot, the mouth will close. So he was putting it in, trying to melt it, and his mouth was closed versus having it hanging open. So, obviously he had a clear nasal passage, but I think those type of things can be very impactful because, he's not speaking clearly either. When we want to speak clear, that tongue needs to be resting up, not down. If it's resting down, we're going to have more lisping. So I think it's just a really tiny little thing that can be quite impactful if parents are on board to do it. Yeah.
But that's a really good idea. So
yeah,
at the end
and little things like tongue clicking, they can always practice tongue clicking or, paddle pop between the lips. Little things like that, I think, can be introduced.
And you mentioned something that I want to just touch on again, because I think parents need to hear this over and over and over and over. In our society, we think teeth together, perfectly straight, that's what we're going for. But in the littles, we want gaps. Gaps are good before the adult teeth come in.
Yeah, absolutely. If a lot of parents are quite surprised to find that if we have no gaps between the baby teeth, it's a severe dental crowding problem when the adult teeth come through. And in fact, sometimes we can get blocked out teeth where, because of the degree of crowding, the lack of spacing, the first permanent tooth comes through and it takes up the space of two baby teeth. And then the next one comes on the inside, like right in the middle of the palate. And it's almost like the child has 3 layers of teeth because that tooth gets in crossbite. And it just becomes more complicated, which is why I love treating before the baby teeth come through. And just having that extra time for the teeth to unravel and come through in the right spots. That's my ideal situation. 5.5 to 6.
Got it. So at the end of every episode, I always like to hand it back to the guest for y'all to have the last word. So any final thoughts for parents or even clinicians that you'd like to share?
Yeah, airway health is really about promoting nasal breathing and good airway development when children are young, because we know that facial structures are growing the most. And it's also about getting their mouth working, their tongue functioning really well as well. And that will help with promoting good jaw development. And so one of the number one key factors to promote good jaw development is going to be nasal breathing, closed mouth nasal breathing, because it is the time where we spend the most, those light persistent forces of the tongue, lightly suction to the roof of the mouth, 24/7, that's actually going to make the biggest difference to the way the facial structures grow. And so what I want parents to understand is that it is not just inside the nose looking for the adenoids and, deviated septums and the turbinates, that there is a very important structural contribution from the jaw. That upper jaw or the palate is the floor of the nose. And so when we've done every other surgery and a child is still not breathing well through their nose, let's not overlook the palate. And let's recreate the space that the tongue needs as well. So that would be the most important thing I think that we need to understand, is not just for children as well, that when it comes to nasal breathing, there's so much new research coming out now that the palate we need to address the palate. And when adults have failed nasal surgeries, what is the common factor? It is actually a high and narrow palate. So let's get this right early on in life, when it's just a lot much easier to recreate that bone.
And that totally makes sense. And when you can breathe, you can sleep better and your child will thrive. And for those who haven't read her book, I just actually did a funny there. So check out Dr. Lim's book, and let's all work to make sure children can breathe, sleep, and thrive. And thank you so much for being on the show again. I truly appreciate it.
No, thanks very much for having me. It's a really hot topic. A lot of parents have so many questions regarding this. So I really appreciate the opportunity to share my insights on what I feel has worked well for parents. And we were talking before about creating more awareness because, for instance, with tongue ties, a lot of parents got their information from Facebook groups. And that's really how come a lot of people have become more knowledgeable and looked into this further and got treatment their child needs. And so I also wanted to say that there is a child palate expander group as well on Facebook. And so I think, for parents, that is something that they can connect to and hear other people's experiences, not just my own, but to hear from other providers and other parents also.
Right. And when you have that information, you can make the best decision for your child. And I will make sure that, I'll make sure that we put that link in our show notes as well.
Fantastic. Thank you so much, Rebecca.
Awesome. Yeah. Thank you.